Hi everyone, in today's video we're going to review the updated pediatric septic shock algorithm, starting right now. Okay, so items from box 1 to box 6 are everything that we should get done in the first hour of treatment in the ER with this kid. Now, moving down to box 7, this is more of the critical care stuff. 1, if the child is not responding to fluids and pressor therapy and they're not improving from everything in box 1, they may require a stress dose of steroids. Hydrocortisone, 1 to 2 milligrams per kilogram. Follow your local protocol. The jury is still kind of out. It's contentious as to whether steroids really help or not. Follow your local protocols, but consider steroids. Next, get a Foley in this kid, right? We're pumping tons of fluid into this kid. We need to measure how much fluid is coming out of this child. So get a Foley catheter in him, make it a temp Foley, so we can watch this child's temperature. We can stay ahead of the game if they start to develop a fever, and we definitely do not want this kid getting cold. So get a Foley in them. Next, we're going to need a central line. We cannot keep pumping fluids and vasopressing drugs into a peripheral vessel. So we need a central line. Get an art line. Non-invasive blood pressure cuffs in kids just stink. They are what they are, and if you've been doing this longer than 10 minutes, you know what I'm talking about. Get an art line. This way we have accurate pressures and we can really manage the fluid and the pressor with a better measurement of their blood pressure, and nothing trumps an art line. So get an arterial line on this kid. One of the most notable changes to the algorithm was the removal of a central venous oxygen tension as a guide for therapy. When we're looking at venous oxygen, it gives us insight to how much oxygen was left over, and that tells us how much oxygen the body used. Great. A central venous oxygen tension is not a surrogate for true oxygen consumption, in that it doesn't include venous blood from the inferior vena cava, the gut, the lower extremities. That has to come from a true mixed venous sample, and I talk more about this in my assessing venous blood gas lecture, but that was removed from the protocol. Now, does that mean doctors aren't going to use it? No, they're still going to do whatever they did that gets their comfort level and the results that they want in this child, but that was removed from the protocol. Next, if the child warrants it, consider intubating and putting this kid on a ventilator. For a couple of reasons. One, right now this child is really working to breathe, especially if this was respiratory borne in nature, if that's where it started from, was a respiratory infection. So by putting the kid down, intubating the child, we're reducing that work of breathing. We're taking all that oxygen consumption needed for him to breathe or her to breathe, and all that ATP they're chewing up, and we can distribute this elsewhere in the body. But we can lower their oxygen requirements just by putting them on a ventilator, sedating them. That gives us a little more oxygen and ATP to move to other parts of the body. When it comes to intubating a child in septic shock, we want to stay away from etomidate. Etomidate can cause adrenal suppression, and we need that adrenal function. It's the adrenals that are producing the catecholamines that are going to help with that peripheral vasoconstriction. So no etomidate. Follow your local protocols, but you may want to consider ketamine, especially again if this was respiratory in nature initially. Ketamine is a potent bronchodilator. So we have the added benefit of ketamine. When it's going to put the kid down, we can facilitate intubation, but it's also going to help to open up those airways, which is a good thing. Lastly, when it comes to kids, and probably the greatest knowledge that any practitioner or clinician can have is knowing your own limitations, right? I'm very comfortable with ventilated kids and ventilated babies, but hey, once that kid goes in a box, I'm out. I need an expert. When I was flying with AeroCare, best company I've ever worked for, best clinicians I've ever worked for. We had NICU nurses and top flight pediatric nurse practitioners that we used to fly the really, really sick little kids. Once a kid goes in a box, I'm not comfortable with that. Comfort and confidence comes from knowledge, taking the classes, doing the reading, putting in the work, combined with experience at the bedside. You're actually doing this on a patient. That's what builds confidence and comfort level. I have no comfort level with a kid that's in a box, but I know who does, so I use that resource. Best nurses I've ever worked with. Now, if you're an ER nurse educator and you had a septic kid in, take the time to review this case. We can elevate that mediocre ER meeting up to a great educational experience by doing a mini grand rounds, pull the records, pull the staff, and review this case. What did we learn from this sick kid that we can take to our next sick kid, which is probably scheduled for any minute now? Okay, this has been a quick review of the updated pediatric septic shock algorithm. I'm Mark, thanks for watching, see you in the next video. You release the pressure, should flash pink within 2 seconds. Great capillary refill.